am very excited to introduce today's speaker to you, and I think that this is going to be a fabulous session. As a public health professional who works and has an interest in infectious diseases, particularly those that are vaccine preventable, Dr. Hinman is a personal role model of mine. So I'm very honored to introduce him to you today. Dr. Hinman is Director for Programs at the Center for Vaccine Equity, a program for the Task Force for Global Health, a nonprofit organization affiliated with Emory University. He received his bachelor degree from Cornell University, his medical degree from Western Reserve University, and a master's degree in public health from Harvard University. Since 1965, he has been involved in public health programs at state, national, and international levels, primarily working with CDC. At CDC, he served as director of the Immunization Division from 1977 to 1988 and the National Center for Prevention Services from 1988 to 1995. In addition, he has worked for state health departments of New York and Tennessee. He retired from the U.S. Public Health Service in July of 1996, having attained the rank of Assistant Surgeon General. He has authored or co-authored more than 400 publications and has served on the executive board of the American Public Health Association and the board of the Gavi Alliance, as well as chairing an advisory committee of the World Health Organization. He is adjunct professor of global health and epidemiology at the Rowland School of Public Health of Emory University, where he teaches courses in immunization programs and policies and health and human rights. So now I'm going to turn the session over to Dr. Hinman, who's going to talk to you about measles, both in the U.S. and internationally. While you're listening to his presentation, I'd like you all to begin thinking about how you can incorporate the information he gives you into your daily practices. Dr. Hinman?
Thanks very much. I start with the obligatory statement that I don't have any relevant conflicts of interest, although you may think differently by the end of the presentation, since I believe in the eradication, global eradication of measles. That is an interest. It's not a conflict of interest. Okay, so what we're going to do is talk a little bit about measles generally, then talk about the situation in the United States, situation worldwide, and then come to an end. How many of you have seen a case of measles? My goodness, about half. How many of you have had measles? About half. Okay, well, you know, 20 years ago, if I'd asked that question, everybody in the room would have raised their hands for both items. So we've made a lot of progress, and I'm going to document a little bit of that as we go along. Just by way of background, measles is one of the most contagious diseases known to humans. It's transmitted as a result of droplets when you cough or sneeze or breathe. It may also be transmitted through the air, and there have been instances in which people have developed measles, have acquired measles in a pediatrician's office, not having entered the office until more than an hour after the patient with measles had left. It's infectious before you see the rash, which is kind of a problem, so that a lot of transmission occurs before the individual knows that they have rash. The complications in the U.S., where we have generally good nutrition, are relatively infrequent. Less than 10% of kids with measles have diarrhea or otitis. Perhaps less than 5% have pneumonia. Encephalitis occurs maybe 1 in 1,000 cases, and deaths occur about 1 in every 10,000 cases in the United States. There was a long incubation period complication of measles called subacute sclerosing panencephalitis that occurred once in several million cases of measles and became manifest perhaps 20 years after the infection. This is what measles rash looks like, and on the bottom row you can see on the inside of the cheek some white spots called Koplik spots. But the general characteristics of measles that we use for clinical purposes are fever, rash lasting longer than 3 days, and cough, coryza, runny nose, or conjunctivitis, pink eye. And these characteristics, if you meet these three characteristics, you are clinically suspected to have measles. In the US, we had annually, before vaccine became available in 1963, we had about 500,000 cases a year reported. But that's clearly an underestimate, because essentially everyone had measles by the time they attained the age of 15. Therefore, the true number of cases that occurred in a year on average was the same as the annual birth cohort. So it was about 4 million cases a year, 3 to 4 million. We had, that we knew of, 48,000 hospitalizations, 4,000 cases of encephalitis, and between 450 and 500 deaths. And this is at a time in the early 1960s when we had good antibiotics to treat complications, bacterial pneumonia, for example. We had effective treatments for diarrhea as a complication. Nonetheless, we had nearly 500 deaths a year in this country. In 1962, Alex Langmuir, who was head of epidemiology at the CDC, in anticipation of measles vaccine, which was going to become available in 1963, issued a challenge to eradicate measles. And in 1963, measles vaccine was licensed and introduced. It was administered initially at 9 months of age. We then found that we got a better response if we waited to the first birthday to administer measles vaccine. So we increased the age at immunization. In 1966, Dave Sensor, who was then the director of CDC, and others published a paper calling for elimination of measles. In 1967, the recommended age of administration was raised to 15 months because there was an even better seroconversion rate at 15 months than there was at 12 months. And children, the incidence of measles had been decreased enough that children weren't really at risk as much if we waited to 15 months. So we had the luxury of waiting to 15 months to get the best possible response to the vaccine. Notwithstanding that recommendation, in case of outbreaks, we recommended vaccinating children as young as 6 months in order to provide protection to 60–70% of them. In 1978, there was another call for measles elimination. I was responsible for that. By 1982, October 1, 1982, in fact, was the date we established as target date for measles elimination. And as you'll see, we missed it by a bunch of years. In 1989, we realized that we got much better protection from measles if we gave 2 doses. A single dose in the US at 12 months of age or at 15 months of age would protect 90+% of kids. However, that left 5 to 10% of children who had received vaccine who were not protected. And measles is so highly infectious that we saw outbreaks of measles here in Texas, for example. In a high school with 95% of the students immunized, we had a very sizable outbreak of measles. And it was because measles was circulating among the 5% who were not vaccinated and the 5% or so who were vaccinated but not protected. If you administer 2 doses of measles vaccine, you can raise the level of protection to about 98–99%, so that we instituted a recommendation for 2 doses of vaccine. Nonetheless, we had a resurgence of measles between 1989 and 1991 as a result of particularly infection in minority children living in low socioeconomic areas who were not vaccinated. We had at that time immunization laws in all 50 states that required measles immunization as a condition of entry to school, and 95% of kids at the time they entered school were protected. However, we were mistaken in thinking that that meant that the preschoolers were equally well protected, and it turns out that in a lot of places, preschoolers didn't get vaccinated until it was time for them to enter kindergarten or 1st grade, and then they got the vaccine. So we saw these outbreaks, particularly in urban settings among urban poor people. And one of the things that was responsible for that was a mismatch between the availability of services and the needs of the population. We had immunization clinics that were open from 10 to 4. 5 days a week, and many working parents were not able to bring their child at that time to a clinic facility. So in response to the resurgence of measles, we had a major change in the approach to financing vaccines in the United States, to supporting immunizations. The Vaccination Assistance Act, which had provided support since 1963 for immunizations, up until 1993, did not support the actual administration of vaccine. It provided vaccine, it supported surveillance, outbreak investigation, and education, but did not pay the salaries of those who actually gave the shots. Beginning in 1993, the Vaccination Assistance Act provided support for that service, and that enabled a substantial expansion in the existence and the open status hours of immunization clinics. Also, in 1993, the Vaccines for Children Act was passed, which provides an entitlement to free vaccine for any child who is uninsured, on Medicaid, underinsured, or is an Alaska Native American. And this basically removed the cost of vaccine, the price of vaccine, as a barrier for children throughout the country. About 50% of American children are eligible for vaccines for children, free vaccines. And a fascinating aspect of all of this, beyond measles, is that when the Advisory Committee on Immunization Practices recommends that a vaccine for universal administration for children, they then take a vote that makes this a part of the Vaccines for Children program and obligates the federal government to establish a contract to purchase the vaccine and provide it to approximately 50% of American children. Doesn't have to go through lengthy congressional hearings or appropriations. It is an entitlement, so the government has no choice but to establish the contract. This has been an extremely important component of our getting to the stage we are now of high coverage against all vaccine-preventable diseases. In 1993, a third measles elimination goal was established. What the hell? You got to keep trying. And as a result of the expansion of services of the Vaccines for Children program, we basically stopped having outbreaks of measles. And in the year 2000, we declared elimination of measles from the United States, meaning that measles was no longer a native disease in the U.S. All cases of measles had their origin somewhere outside the U.S. An extraordinary achievement. I was only 18 years late in delivering. Close enough for government work, right? Okay, so this is what the incidence rate of measles looks like. A major decline immediately following the introduction of vaccine, then a rise in 1969, 1970, which interestingly was due to the introduction and licensure of rubella vaccine, which everybody was really worried that we were going to have another epidemic of rubella and of congenital rubella syndrome. And when Congress passed the reauthorization of the Vaccination Assistance Act, they said that these funds can be used to support rubella immunization. They didn't mention any other disease. So we found ourselves for a while with no federal support for the purchase of measles vaccine. And as a result, for example, I was at that time, I was in charge of the immunization program in New York State, and we were totally dependent on federal funds for our measles vaccine. So for a while, we weren't vaccinating against measles in New York State. Oh my God, how can that be? We finally got some state funds, but this was, you can see, reflected in an increase. Then you can see also in the resurgence of measles, 1989 to 1991, and then very low levels since. This shows an expansion of that portion of the graph. And if you consider the incidence of measles on the basis of number of cases per million population, we have established that a level of less than 1 case per million population is consistent with no ongoing transmission of measles. And you'll see that since 19 97, we've been below 1 case per million, until this year. And we're going to talk about that in just a minute. This slide depicts in blue the cases of measles that are direct importations, that is, people who travel to another country, acquire measles there, and then come home. And then in red, the non-import cases. Some of these are import-related or import-associated. They're people who came in contact with an imported case. This slide depicts the region. The World Health Organization divides the world into 6 regions. And this shows in different colors the source of importations of measles. And you'll see a few years ago, European region was the major source of measles into the United States of importation. In fact, Switzerland, as an individual country, was an important source of importations. We also see importations from Southeast Asia, and then in the last couple of years, and particularly in this year, from the Western Pacific region. We have had, since 2001, a very limited number of outbreaks that have had at least 20 cases of measles, which is incredible. We used to have outbreaks with hundreds and thousands of cases. Now we get excited about having an outbreak of 5 cases, and if it's 20 or more, then we get really kind of worried. And these are pretty expensive because we have, since we consider that measles is no longer a native disease in the United States and it's intolerable that we should have measles transmission in the United States, we take aggressive action in response to cases. And that incurs a fair amount of costs. And these are estimated costs from outbreaks in the US in the last 10 years. And you see that nationwide in 2011, we had 16 outbreaks of measles with 107 cases, and we estimate that it cost between $2.5 and $5 million extra in public health expenditures. This is nurse time, epidemiologist time, clinics time, this kind of thing. So this is not an insignificant cost. So as of mid-September, we had 594 cases reported from 22 states. At that time, we'd had 50 importations, half of them essentially from the Philippines, and the majority of the imported cases were in U.S. citizens, U.S. residents. And the specific source was a problem was a big outbreak centered in Ohio, which arose when a group of Amish people who were unvaccinated went to the Philippines to provide, on a mission to provide relief, post-hurricane relief, and there was an outbreak of measles going on in the Philippines at that time, and they brought measles back to Ohio, and it spread within Ohio and outside of Ohio. I'll show you a slide in just a minute. This just depicts the various outbreaks in the U.S. this year, and you'll see that the Ohio outbreak accounted for 377 cases out of the total at that time of 590. We are now, as of October 31st, we have had 603 cases of measles reported in the United States in 20 different outbreaks. This is the largest number of cases reported in the U.S. in 1 year since 1994. It's a 20-year high that we're at right now. This is a little bit of about the Ohio outbreak. I'm not going to spend a lot of time on it. It was clearly primarily around the county, Knox County, where the community, the Amish community, was living, but there was no spread to the larger Amish community nor outside the Amish community. And it's of some interest that, at least I don't know as much about this specific outbreak, but the last outbreak of polio we had in the United States in 1979 also had its origin in Amish people. And it was a virus that had traveled from the Netherlands, from a group of the Dutch Reformed Church, to Canada, where there was a similar group. And then Amish people from the US, since Amish people tend to marry other Amish people, has been a real problem of inbreeding in the Amish communities. And in fact, they've been very carefully studied by human geneticists who have recommended that they try to diversify the gene pool somewhat. So young Amish men take bachelor trips to visit other Amish communities in hoping that they'll find someone they would like to marry and who would like to marry them. And this apparently is how poliovirus was brought into the US from Canada and then spread within the Amish community. Although the Amish people don't believe in vaccinating themselves. They believe that illness is something that God brings on you, and they're willing to take that risk. They didn't want to jeopardize the community. And so in 1979, we were able to vaccinate about 75% of the Amish community because they did not want to be the source of illness among the larger population. And there has also been pretty good uptake of measles vaccine among the Amish community in Ohio as well. So their opposition to vaccines is not total. This just shows the age distribution. I don't want to spend time on that. Let's talk now about measles around the world. Before measles vaccine was introduced, we had about 5 million or more deaths a year due to measles. Everybody is infected with measles unless you live in a very, very isolated community. And then, if you do, if measles comes in, they have massive outbreaks. And one of the most famous studies of measles epidemiology ever was an outbreak of measles that occurred in the Faroe Islands, a territory of Denmark, in the mid-19th century. There had been no measles in the Faroe Islands for more than 60 years when a sailor landed and went ashore who had measles. And he introduced measles to the Faroe Islands. And in very rapid order, everyone on the Faroe Islands less than 65 years of age developed measles. And an intern from Copenhagen, Peter Panum, was dispatched to try to investigate this. Now, this is before the germ theory of disease was known, and he made very, very careful observations which established the fact that there's an incubation period of measles of approximately 10 to 14 days, that if you've had measles once, you're not going to get it again because no one over 65 got measles, and that the period of communicability began even before the rash appeared. He basically described perfectly the epidemiology of measles without knowing that it was caused by a virus. He just was really brilliant observational work. Well, measles vaccine was introduced worldwide in the developing countries not until the mid to late 1970s with the formation of the expanded program on immunizations in 1977. And we saw widespread adoption because particularly in African countries, everyone feared measles. All children got measles basically before the age of 2, and as many as 5% of kids with measles in some of these countries died, particularly if they were malnourished. And in some communities, children were not named until they survived measles because a name would only be used once, and you didn't want to waste it on an infant who was going to die of measles. So there's been good appeal and interest in measles vaccination in developing countries. And we saw a 77% decrease in incidence and a 78% decrease in deaths in just the first decade of this century, between 2000 and 2012. And since 1985, in the last 30 years, we've had a 90% decline in deaths due to measles. Nonetheless, we still have more than 100,000 deaths a year due to measles, which works out to about 14 deaths an hour. So while we're here this morning, somewhere in the world, 14 children are going to die of measles. And this is really tragic because these deaths can be prevented if we only administer measles vaccine. So the World Health Organization has 6 regions, which are shown here in different colors. All 6 regions have now established targets to eliminate measles no later than 2020. And 2 regions have established targets to eliminate rubella. And I think more regions will establish these targets as time goes on. But we now have global commitment to interrupt measles transmission around the world, which will be an important step on the way to eradication. And here's where we are with respect to coverage with measles vaccine. The bars represent the global coverage, and we're now above 80%. We're estimation at 84% of children around the world have received measles vaccine. But this varies greatly by region. The African region, shown in red, has the lowest uptake of measles vaccine, but it's still in the 70s, which represents a significant improvement from where they were at the turn of this century, when they were only at about 50%. The Western Pacific region, the Americas, and Europe are all at or above 90%. And this map depicts country by country the coverage levels. You see there are still 4 countries with coverage less than 50%, and then a bunch of countries that are between 50 and 80%. Wow, this is a repetitious slide, sorry about that. And this shows what the reported rate of measles was, country by country around the world, in a 12-month period from May of 2013 to April of this year. And you'll see that the highest incidence rates are in sub-Saharan Africa, with significant measles incidence in the former Soviet Union, and a substantial amount of measles, interestingly, in Australia. As a result of activities in the Americas, which were designed to try to interrupt measles transmission in the Americas, a strategy was undertaken in the Americas that involved what is called catch-up campaigns, in which all children between 9 months and 15 years of age would be vaccinated in a mass vaccination campaign, whether they'd received measles vaccine or had measles disease, every child between 9 months and 15 years. The second arm of that strategy was called Keep Up, which is to maintain high immunization coverage through routine immunization services. The third leg of this strategy was called Follow Up, and this represented mass campaigns every 3 or 4 years to vaccinate the children who'd been born since the last campaign. So what this did was provide 2 exposures to measles vaccine to every child. And this strategy succeeded in interrupting measles transmission throughout the Americas. And in fact, since 2002, measles has not been a native disease in the Western Hemisphere until this year, when Brazil has been reinfected and has reestablished endemic transmission. That strategy was slightly adapted for use in other parts of the world with routine immunization activities, the second opportunity for measles vaccine, surveillance, and improving case management. It turns out that if you give vitamin A to a child with measles, you can reduce the likelihood of death from measles. And what often this protection lasts for some months. So what happens in many countries is they have campaigns twice a year with vitamin A drops for children, and that has resulted not only in a decline in measles mortality, but also a decline in general childhood mortality. We've established a major network of laboratories that are capable of diagnosing measles and rubella, either serologically or through virus culture. And you can see here the progress in the Americas with the last endemic measles case occurring in 2002, up until 2013. So we've made great progress globally in reducing measles deaths, and you can see that on this chart. Sorry, this is a borrowed slide, and I didn't know how to get rid of the animation. And we have prevented more than 13 million deaths since the turn of this century. However, measles is such an infectious disease that if we stop doing what we're doing, it's going to come right back. And this is based on modeling, shows that if we stopped doing what we are doing, within 5 years, measles could be back up nearly to the level it was in 2000. So we've got to keep it up. Boy. These are the campaigns that were carried out in 2013, and there were 33 countries. In 14 of these countries, vitamin A was also administered. In 12 of them, drugs were given to deworm children, and other interventions were applied in five other countries, including distribution of insecticide-treated bed nets, for example. And this just shows measles in Europe and shows different countries affected in different years. We've had outbreaks in Europe among under-vaccinated groups, the Roma, travelers, followers of anthroposophy, which I don't really know what it is. But it's a philosophical movement that doesn't accept immunization. The Dutch Reformed Church in the Netherlands, ultra-Orthodox Jewish communities, schools and educational facilities, and healthcare settings. Measles transmits very well in hospitals. And in fact, in some countries in Africa, they used to vaccinate children with measles vaccine on admission to hospital to prevent their acquiring it while in the hospital. And this just depicts the spread from the Philippines of measles in the past year, with the U.S. having been a major target. And we're doing better. We've got more than 80% of children vaccinated against measles, but there's still more than 20 million children who have not been vaccinated, 60% of whom live in India, Nigeria, Ethiopia, Indonesia, Pakistan, or Democratic Republic of the Congo. As I said at the beginning, there may be some conflict of interest, since I've been on record since 1982 that we should eradicate measles from the face of the world. So in conclusion, measles has been and still is a major killer of children. We have very effective strategies to prevent measles. We just need to implement them fully. I believe that measles eradication is inevitable. The only question is when we will do it. Thank you very much.